Yes, ma'am, you are audible.
Okay, fine. Good afternoon, everybody. My name is Smriti, and I am the Director of Programs at Pallium India. And I'm very, very pleased to have you all here in the 19th session of our PalliCovid ECHO. This has been a very interesting journey for all of us, and this program and all the resources associated with this program have been put together by a very diverse group of people from different disciplines within the medical fraternity. We have had experts from anesthesiology, from neurology, pulmonology, critical care, and of course, palliative care, psychiatry, psychology, be contributors to this program. And over the course of this week, you will meet several faculty members. So the contributors have also doubled up as faculty who will be leading these programs. And I'm sure that it'll be a week of mutual learning. We're here to learn from you as much as we're here to share with you what we have put together. I would like to just run through some housekeeping rules before we start the session today. Firstly, all of you have been muted by the host. That's only to maintain the fidelity of the session while it's in progress. And if anybody would like to share something, you're more than welcome to use the chat box. We encourage you to use the chat box to ask questions, to share an experience that is relevant to what is being discussed. And what we follow here is a flipped classroom method, which basically means that the resource toolkit has been shared with you in advance. All of you have received it a week ago, and it is also, the links are there in all the emails you get on a daily basis. What the flipped classroom methodology really relies on is shared learning. So it's ideally done when you read about the topic in advance in the ebook and watch the relevant webinar that goes on that subject, and then come to the session having done those things, so that there is a little bit more cohesion in what is being shared during the session with the experts themselves. So please take some time to spend some time on that resource toolkit, which includes an ebook as well as 8-9 webinars that have been put together by all the experts. Please ensure that all your names are displayed on your devices. This is absolutely essential for us to be able to record your attendance. And it's very important in terms of your certification to make sure that your names have been registered and have been accounted for by our tech team. If you're not sure how to do that, if you go to the corner of your screen on the right, you'll see 3 dots. You can click on it, and you have the option to rename. If you have difficulty doing that, please enter your name in the chat box so that we know which device goes with whom. And the other thing is, in order to receive the certification for this program, it's essential that you complete the pre and post evaluation. This is not a test, it's an evaluation of the program itself that allows us to constantly improve upon it. But that pre and post evaluation is absolutely essential for you to receive the certification at the end of this course. We encourage you to be interactive. And like I said, what we normally do is we have a lead facilitator who takes us through the session, and we have a co-facilitator who manages the chat box. So there's a constant interactive option for you. And the co-facilitator will then take the questions that are coming up in the chat box, summarize them, and take them to the lead facilitator to address. And towards the end of the session, we will have a little bit of room for us to interact with one another. So that's typically how these sessions go. And I'm very pleased to tell you that in the 19 weeks that we have run this program has touched 29 states in India, 28 states and 4 union territories. And we have also had participants from 12 different countries. And I'm particularly pleased to welcome our colleagues from the Philippines and from Ghana today for making the time to be here with us. And all of you who are logging in from different parts of India, thank you. I know these are very busy times and stressful times for a lot of you, and for you to come and make time for this session means a lot to us. I'm now going to introduce you to our lead facilitator for today. Her name is Dr. Rajni Surender Bhatt. Rajni is an interventional pulmonologist, trained also in critical care. She's been very, very actively involved in COVID management right across the country, somebody we rely on quite heavily in our own consults. And Rajni has been faculty on these sessions for a long time now, and she takes sessions both in Hindi and in English. This week, of course, is English. So I will be the co-facilitator for today. So please feel free to address any questions or comments you have in the chat box, and I will bring them to Rajni's attention as we go along. So to take us to today's session, which is basically an introduction to the PalliCovid course, and then going into triage and ethical goal setting, I'm now going to hand over to my colleague and friend, Dr. Rajni Surender Bhatt. Rajni, over to you. Do you need, yeah.
Apologies. I was having a few issues with connection. Thank you so much, Smriti. And a very good afternoon, good morning to all of you across the world. So grateful that so many of you across India and in other countries have taken the time for this program that has been put together with a lot of thought and intention in supporting the needs of uh, patients as well as healthcare workers in these.
Sorry, we're just having some connectivity issues. One moment, please. Rajni, we will need to mute your other device. You're logged in from 2 devices. If you could just mute the other one, that'll be great.
I've muted the other one, and I think that should work. Is this
yes,
better?
It's absolutely fine. Yeah. Right. Over to you.
Okay. All right. Thank you so much. And again, sincere apologies for the technical glitches that have kept us from getting started on our session. We hope to catch up and make up on time. So as I was mentioning, this is a trying time for all of us. I think most of us have we've only seen reports of one or two individuals across various continents who have seen the last pandemic that this planet faced. And for every one of us who is in healthcare at the moment, this is an unprecedented situation that nothing in our experience had prepared us for. It's the kind of stuff that we read in our textbooks, but we never had to witness or experience or learn how to manage and cope with the challenges that come with a pandemic. And therefore, it's really a blessing that so many experts have put their minds together and created this toolkit, which is something that we can all use and find that there's knowledge that we can use from the experience of others across the world who worked in difficult conditions. And I think it's really wonderful because it's for many of us, we've not been exposed to the concepts of palliative care in the past, and we find ourselves in pressing circumstances where this has become extremely essential. Can I check and see if my screen is visible to everyone? It's visible. Wonderful. So the goal in putting together this toolkit by the core committee of the PalliCovid Kerala Alliance was to provide a resource which would help to train, support, and empower healthcare workers who are caring for seriously ill patients and families during this pandemic. And the areas that we're focusing on in over the next 5 days that you'll experience with all the material that will be provided to you is to assist us in taking care of people who are infected with COVID and those who are affected by COVID as well. So that would be those who are COVID-19 positive and who are facing health challenges, as well as those who have other medical conditions, pre-existing medical conditions, or new things that come on, but are now having to face the challenges of access to healthcare, providing accessing the appropriate healthcare in situations like the lockdown, with many nations across the world faced with restricted access to hospitals and clinics, and also recognizing the greater challenge that healthcare workers are facing with their own health. We know that healthcare workers are at greater risk for infection and have had higher mortality in terms of the disease itself compared to the general population. So this resource toolkit is something which is going to help us in addressing all of these specific groups, those infected by COVID, those affected by COVID, as well as those who are taking care of these patients, families, and community. Um, when any kind of a training or knowledge, expansion technique that we're looking at certain competencies that we want to focus on. And so the steering committee has identified certain areas that they hope that all of us will gain competency in. I can tell you that I'm someone who, as Smriti mentioned, I've worked in the area, but I've also been a student of this course. I started off as someone who took the course as a participant and then went on to apply this. And I've also now, I'm interested in sharing that knowledge which I have gained with everyone. So the most important part is to recognize the impact of this COVID-19 pandemic as it applies across the board in the medical field, and to understand that the holistic needs of the people who are affected by it. It's not just the physical. It's not just the part of people who are infected by COVID, but we know the circumstances people are facing with isolation, with the use of PPE, with not being able to meet family members. And these bring us challenges to be able to effectively communicate with patients and families in the context of COVID. The fact that things can happen so rapidly, so our skills in communication are tested. We have to set goals with families and help them with decisions in a time frame where we've not had the time to establish a relationship. The medical knowledge regarding COVID has expanded. Again, this has been a rapid explosion of research and medical science. We've seen more publications come out. I'm sorry, I think there's one participant who's raised their hand, and I would like to check and see if there's anything specific that they would like to address. So may I ask, I think it's
I think,
Bindya ji?
yeah, it was Bindya. Bindya, would you like to say something, or is something would you'd like to share with us in the chat box? So, Bindya, if you would like to just say, if you could just write in the chat box if there's something specifically you would like to share verbally, then we will unmute you. Rajni, till we hear from her, please carry on.
I will. So uh, it's challenged our skills in terms of establishing rapport relationships, communicating, setting goals early, right from the time of hospitalization or even detection of the disease. And as medical knowledge has expanded rapidly, drugs have come and gone, treatment protocols have come and gone. So it's very important that we understand the thinking behind the algorithms, which remains common. What is the common theme across all of this? That even if the medications and the treatment regimens change, there are certain parts of caring for patients which remains universal. And if we continue to apply that, then we can really do well by our patients. So there's wonderful management algorithms for certain common symptoms that you will see in the context of treating COVID, and understanding the medications that are available for us, which will not change despite whatever is happening through the research that's coming through. There are certain constants that we know are there as tools, medicines available to us for helping relieving the suffering of our patients. The other part is to recognize and assess. This is now we're getting to the part which is beyond just the physical treatment of the ailment, but to understand the distress that patients and their families experience, to understand the role of the healthcare team in providing psychosocial and spiritual support to these patients, and understand that there are some that we will not be able to help despite the best advances in medical science. and to ensure that the end of life care in different settings, and this could be whether it's in rural areas, tertiary centers, this applies across the board, that we must make sure that there is good end of life care, and that there is dignity in death, there is room for people to grieve and express their bereavement, that there is room to address the isolation and loss that people suffer. In all of this, we must also keep in mind that we must learn the sensitivity towards our team members, to healthcare workers, to everyone who's part of this system, and know that we're all going through an extremely fatiguing process. We're now, 10 months into the pandemic, and it shows no signs of letting up yet. So to understand that we ourselves are at risk for burnout, and make sure that we create the psychological safety and the compassionate environment to foster that ability to be able to continue to care for others through all of this. So, we were talking about the challenges of this pandemic just a little while ago. Smriti and I were discussing before the start of the session. And I told her about a message that I got from a friend. And it was something that really moved me. It's the kind of situation that we're seeing a lot of nowadays, which we didn't have to address earlier. So, what happened with my friend was, my friend is in Bangalore, and she received a message from her uh, relatives in Chennai. Her cousin and aunt were both infected with COVID. They had just been detected 3 days before and had deteriorated rapidly. Her cousin is 39 years old, her aunt is 62 or 64, and she's a diabetic. They both were requiring oxygen. They had been brought to the hospital. It had just been 2 days of fever, and by the second day, their breathing was labored, and they were brought to the hospital requiring oxygen. Now, at this point, what was really distressing to the family was that the doctor said that, look, I see them right now at the emergency as they are, and I anticipate that they may get worse. The current situation in the hospital is such that we have one ventilator left right now. So I would advise the family that you please start looking for another hospital which can accept them. Considering that there's a shortage of beds all around across the city, I want you to know that if things go down simultaneously, that both of them take a turn for the worse, the decision that I am faced with is that between the two of them, your cousin is more likely to survive and recover from this illness with the best that technology has to offer. And imagine the condition of this family where they know that getting a bed in a hospital has become difficult because of the number of patients across the city needing healthcare. Knowing that uh, the doctor is faced with this ethical dilemma and has to, within a matter of like 45 minutes of meeting this family or having a discussion like this, where I don't want to have to choose. I know that you feel you brought them to a safe place right now, but this is my limitation. Our resources are limited. You will need to continue to search for another place so that both of them can be safe. And the family had to continue looking for another place for her aunt. And luckily, at the moment, they are both being treated in ICUs in two different hospitals in the city. But these are the kind of challenges that people are facing. I'm pretty certain many of you have heard stories like this. Um, and it's an extremely intense and difficult decision to make uh, for the patients' families, and even for the doctors and nurses and the ambulance emergency workers, everyone, when they're going through these situations. That they also, all of us are human, and they're experiencing the challenge of a healthcare system which is being stretched to its maximum. So in these situations, it's very important that we understand the competencies that we need to have in order to provide the best in the limited resources. So the key domains that were that have been put together with a lot more focus for everyone to learn and internalize are these, and that's triage, symptom control, the management of distress, end of life care, and supporting the healthcare worker. So we're going to be spending a lot of time in addressing all of these. The resources that have been put together by the PalliCovid Kerala Alliance are in the toolkit that's been given to you that you have access to. So there is this online training project where you will be coming and spending time with us for an hour every day for the next 5 days. There are PowerPoint presentations with voiceovers that are available for those of you who might have network bandwidth issues, so you can listen to those lectures at leisure. There is an ebook which also has all the material that will be discussed and the webinars that are available on the website. So I would strongly encourage all of you to look at each of the lectures, the content that is going to be coming up for the next day's lecture, maybe the day before, because then you will get the maximum out of it. It would really be useful because we've seen in the past weeks that whenever all our participants come in with a little bit of reading beforehand and their own experiences, we learn a lot from them. There's a lot more knowledge sharing that goes on.
Rajni, if I may interrupt for a second, just one thing, your audio is a little bit shaky, I think, because the mic is moving. So if you, it was a lot clearer when you had it closer. So that's one, there's less disturbance that way. Also, just to point out to you that we have a very, very, I mean, some of the participants have already shared their interest in why they're here. And also amongst us is a doctor, Dr. Owais Hamidar from Jammu and Kashmir, who himself is a COVID survivor. And so, yes, and we have somebody who's working in a humanitarian setting. We have other people from nursing. We have, so it's a very varied group and a lot for us to learn from them as well. So as we go along, we will invite them to share some of their experiences with us as well. Thanks, Rajni.
Thank you so much, Smriti. And I think that's been one of the greatest, I think, I mean, it's hard to call it a positive, but one of the things that I have appreciated the most through this entire time with the pandemic has been the openness across the entire medical fraternity across the world in terms of sharing their knowledge, their experience, and their expertise. And we're truly fortunate to have people who come with such a wide and rich experience and learning to share with us. So we really look forward to that. And with that, so I'll move on to. And I think Smriti also might have mentioned that we have in our faculty itself, we have a very very diverse faculty. We have experienced nurses who have been teaching experts in the field of palliative care for decades. We have psychologists, we have neurologists, we have pulmonologists, we have anesthesiologists. So there's a very strong, diverse faculty whose experiences we've drawn from in bringing forward these sessions.
And Sister Stella is with us here today. So we will we have the nurse's perspective also as we go forward.
That's one of the most valuable inputs that we've had with Sister Stella coming in, and I think we've had amazing sessions with all the nurses joining in from across the country. The perspectives from different areas. It's been an eye-opening learning experience for all of us to know the challenges. Sometimes we tend to think within our silos of one state or another state or one particular healthcare setting, but the sharing of experiences from across the country has meant that we've understood challenges and learned from the solutions they have come up with in their local situations as well. So, in this teaching modules that you will see in the next few days, what the attempt has been is that it's not going to be so much of a complete theory type of a discussion. There'll be some signposting to relevant resources which is there, but we're really looking forward to this discussion and interaction. We've had alternate weeks of English and Hindi, and um, the idea is that it would be wonderful if you can share this knowledge with other people as well if you find it useful to you, and you can reach out to the team in case you would like to adapt it to your settings or to translate it into other languages as well. And we would really encourage that. The idea is to have something which is open source and shareable for more people to access and adapt and use. So with that, let's talk a little bit about palliative care. And I think Smriti had started that conversation when I was disconnected for a while. And maybe Smriti, you can share a little bit of what the participants, what their experience in palliative care has been. And let's understand that before we move on.
Yeah, so thanks, Rajni. There are a few people who have shared. For example, Sinu Chako from Pune has told us that she would like to learn more about mainstreaming palliative care in disaster settings, especially in light of COVID-19. And although she doesn't have a clinical background, very keen on research and advocacy. And that's something that resonates with us at Pallium India to a massive degree. So we have a lot to learn and share with each other. We also have people who are familiar with palliative care, and but I think a lot of people are working in other settings, so this might be a new approach, in particularly in the management of COVID-19 settings, because I think typically palliative care has been seen, as usually associated with end of life care and things like that. But yeah.
Yeah. So I think that reflects very much to what most people's experience or understanding of palliative care is, including mine until I came to a certain level in my training. I think when I was in my undergraduate training, I thought of palliative care as something that was reserved for mainly patients with cancer or those who have debilitating, painful conditions or at the end of life. And it was only after one started studying and seeing the use of palliative care in various other, even through my residency in internal medicine. I think that was my concept of palliative care. It was restricted to oncology, but it's only later that you started understanding that the scope of palliative care is so much wider. A lot of professional bodies across the world have recognized this shift in their thinking. The palliative care medical community, of course, has been doing a tremendous job in sharing their knowledge across the world, but it is a two-way, it is a conversation between different specialties, and the rest of us have been slow to adapt, I would say. So even the American Thoracic Society, it's only about 10 years ago or so that it adapted to the idea that palliative care is something which begins at diagnosis. So the earlier thought was that there is a curative or restorative part of treatment, and there's a sharp line, and then if that's not working out, then after that it's palliative care. But what you see on your screen right now is the current concept of how palliative care is relevant throughout the course of a patient's life. And that is right from the time that there is a suspected disease and a diagnosis that's established, to when there is curative, restorative, rehabilitative treatment going on, to a point when there may not be a chance at curative or restorative treatment. And at that point, you are providing supportive or comfort care, and also at the point of death, and after that for the family with bereavement. So palliative care has a much wider scope through the entire spectrum of a patient's experiences in healthcare. And the idea is to provide active holistic care to people of all ages with serious health related suffering. And this is an important word, to understand suffering of the patient's experience of their disease. And the idea is that we improve the quality of life of patients and their families and their caregivers. So it's not purely elimination of disease, but it's improving the entire quality of life, and it's addressing everything that is causing suffering to the patients and their families. So this is a much more holistic concept of what medicine is about, what health and well-being is about, addressing the quality of life. And this, we can obviously understand, extends to every kind of illness, whether it's cancer or other non-communicable diseases, or even very severe infectious diseases. We've known of relief work in humanitarian settings for a long time. When it's again that this pandemic is the first in 100 years which is hitting the world so hard. But there have been epidemics in the past. There have been natural disasters in the past, which cause an upheaval in society in a way uh, that causes physical and mental health devastation in entire populations. And there has been a very large role that palliative care plays in this setting as well, to provide support and relief of suffering for these communities. And there's a wealth of literature about this as well. So we've had displacements due to war, where refugees are coming across borders, or you have natural disasters like floods and earthquakes. And we've had outbreaks like Ebola or the previous SARS epidemic, which happened in the past, where palliative care has had a role to play. So, what has been unleashed that we are seeing now is something that we've witnessed in small geographical pockets in the past, but it is a worldwide wave, it is a tsunami, and it offers many areas for palliative care interventions. And across the world, whichever part of the world we're in, these elements of what we can offer in palliative care will remain common. And that's to be able to improve the communication and to help people setting goals of care, to provide better symptom control to those who will not be benefiting from intensive aggressive measures, to provide psychosocial and spiritual care, end of life care, and to be able to support the essential workers in order to maintain their health and well being so that they can serve their communities. So, this is the entire scope that's there. For an extended period of time, as we can see it. So it's even though this hasn't been a focus in a lot of medical education programs or national programs, this is essential front and center right now for from this point going forwards. And recognizing that, the 73rd World Health Assembly made this a part of their COVID-19 response statement, where governments committed to delivering palliative care services along with the intensive measures of testing, tracing, treating. Governments must pay particular attention to protecting those with pre-existing conditions, is what the statement said. For those with pre-existing health conditions, older people, and people at risk, including healthcare workers. So the stress and the particular risk to these specific populations was recognized, acknowledged by the World Health Assembly, and the governments were directed that we must take steps to ensure that palliative care is provided to these communities at risk. We've seen the worst kind of suffering through this time, and there are certain populations which have been hit with it much harder than others. So there are those who have been displaced, there are refugees like those coming across the borders into some parts of India. There are people who are in prisons, who are in crowded conditions, who are much more disadvantaged and at greater risk if even one of them gets the infection. There are people who've been displaced by war and escaping from areas of strife, and there are people in refugee camps. And even here, you see that uh, they're doing their best to take the measures, to have distancing, to have masks, and make sure that we're still trying to provide um, safe support to people in difficult conditions. And as we've seen the worst of suffering, we've also seen the helping hands come forward. In India, we faced a very large crisis with following the lockdown, with the movement of workers from across different states to their homelands. And there were people who did not have jobs, who didn't have food. Hunger was a big issue, and you saw communities and charitable organizations and governments coming across to help those in need and providing transport, food, um, shelter until they could reach their homes. And the general it's along with the worst that we sometimes see with people attempting to protect each other. It's a misguided sense of protection which sometimes stigmatizes those who are affected, but there is also a larger sense of community coming forward and coming together to help. One of the things that has been this was a really striking quote by Dr. Laura Colby, who's a hospitalist in New York. And one of the striking things that we notice about palliative care is that even though access to palliative care has improved across the world, I mean, if you look at it, about I would say around 80-90% of the population in the United Kingdom has access to palliative care services, and anywhere between 45 to 70% of the population in the United States has access to palliative care services, as in there is someone available within a range that they can travel to. When we think about it in that context, when we look at our country like ours, which is so large with this varied geography, the access to palliative care is less than 4% of the population has access to palliative care. And that's when we talk about that, we mean people who have specialized training in palliative care. So it's very important that the rest of us upskill ourselves. Even if I am not a palliative care physician, I need to upskill myself to have the basic generalist palliative care competencies to provide the appropriate care to my patients. And this is what Dr. Laura Colby voiced um, in a write up that she had put forward, where she said all doctors are palliative care doctors now. And this was early in the pandemic. We didn't have medications, we didn't have treatment regimens, we didn't have algorithms for managing mild, moderate, and severe disease. And all that one could do at that point was to make sure that the treatment was according to the patient's values and priorities, give the recommendations with the best knowledge that was available to us at that time, and bear witness and give them company in their time of suffering. what was most distressing to families at that point was that their loved ones were alone in hospital, breathless and in suffering with no one next to them. And just knowing that there is a doctor, there is a nurse, there is a therapist who is spending time next to my loved one and reassuring them, connecting them with a few words on a phone now and then. That is the best service that we could provide to patients at that time. And that's what she voiced when she said, all doctors are palliative care doctors now. We must attend to the suffering of patients, even if we cannot treat and cure their disease. Um, and this is essentially in a nutshell, all of what we're hoping to achieve in the next 1 week. We are all united in our suffering right now across the world, and we're all very starkly aware of our mortality. There is no one on this planet who is going to remain untouched by this in some shape or form. And might try as we might, we're not going to, we can't escape that fact. And we need to prepare ourselves for it. And I'm going to take a short break here to check with Smriti if there's any other thoughts or observations. And in the interest of time, I think we should move on to the next section. Your thoughts, Smriti?
Nothing so far, Rajni. I think we're good to move on. Like you said, in the interest of time, we should probably keep the pace. Yeah.
So let's move on to the first part of our the core of our discussions for the coming week, and that's triage and COVID. Now, um, triage is always something that is fraught with making decisions quickly. We have certain ideas in our head about this person needs emergency attention, this person can be managed on the outpatient basis, someone needs the intensive care, someone is okay in the ward. There's a lot of decision making that happens, and I think all of the people who are participants on this have faced this at some point in their life, right? I mean, in our professions, we come across multiple decisions that we make in a split second, multiple times through the day. And it's always good to have a certain framework in our mind which helps us to make those decisions in a logical and ethical manner that's appropriate for the patients at that time. So we're going to explore that a little further with respect to COVID, especially with respect to the ethics in the management of COVID. So I'm going to start by, so we're going to look at this background of ethical decision making, and we'll see how to balance out these different ethical principles, because sometimes they may not all be in agreement at the same time. We look at what do we what do we want to achieve when we are planning triage of patients, and what are our goals of care. And there's plenty of more tools available in the ebook that you can refer to later, but we'll discuss one or two of the algorithms in a little more detail. So I'm going to ask the participants to share with me what are the four principles of medical ethics that are the foundation, that these are the pillars on which we build the rest of our treatment plans for our patients. So I'm going to take maybe a 10-15 second break and give everyone some little time to respond to that. So if you can share with me the principles of medical ethics.
So the answers have started coming in. Mohsin says autonomy. And I'm going to encourage the other participants to also put in their inputs as we go along, please. Beneficence, non-maleficence, justice. Yes, it's all been covered.
There, we've got all the answers right there. Thank you so much. Yeah, and autonomy, that it's the fundamental right of a patient to decide what happens to them, and patient autonomy, even in a pandemic, remains a founding principle for us. There is a certain sense of control that unfortunately is given up in the context of a pandemic in the interest of public safety. And this is the one part. So, as I mentioned, we are going to be looking at the conflicts that we will face in decision making in the setting of COVID-19. So, what we will try and find that common thread through all of this is that even though there are certain conflicts in ethical principles, uh, these ethical principles are universal. They remain the same no matter which country one is in, no matter what kind of culture one practices in, and whatever is the setting of our practice. There may be minor changes depending on this context of pandemic, because you're looking not just at the medical ethics from a personal, patient, individual point of view, but also looking at it as community application of medical ethics. But essentially, the four principles remain the same. And whatever legal frameworks are there in each country, they usually reflect these ethical principles and are according to the cultural norms of that particular population. So we work within those frameworks, but we continue to apply it even in extenuating circumstances of pandemic. So these are the conflicts that we sometimes face, that we have to apply when we are looking at treatment options and setting goals of care for our patient. That is a particular treatment option, is it going to be beneficial or non-beneficial? Would it place an undue burden and actually cause harm to the patient, or would it be an inappropriate use of resources which could be used wisely elsewhere? We have to look at the legal frameworks. In each country, these rules might be different. And especially around end of life care and advanced care planning and advanced medical directives, different countries will have different rules. But we can still work within that legal framework applying the same ethics. And we must keep in mind that it's always the best interest of the patient that we're working towards, while understanding that in a pandemic, certain aspects of autonomy are mildly compromised because of public safety. So, when we look at the idea of isolation, for example, patients who are positive having to be isolated, here, this is one of those areas where if one is not able to self isolate at home safely, then the public authorities do take over and say that in the interest of protecting the rest of your family or the others in your house, you are requested to go to a COVID care center. So there is this little compromise here, but you will see that it is still with the idea of justice for everyone else. So it's about which ethical principle takes precedence over another, keeping in mind again beneficence and non-maleficence. So this is how the ethical frameworks are applied at all times, even in a pandemic. So it's like a fine, tightrope walk, which is challenging at times, but it can be done as long as we keep the founding principles in the back of our mind. And the next few days will be about how to navigate this maze of decisions that will keep coming up as we encounter situations in our clinical practice which are challenging on many, many fronts. Um, the issues with COVID especially come up because some of the patients are so vulnerable, and the fact that the patients and families are isolated from each other, where there is a lot of misinformation that's going on. Most of us have seen how social media has fueled misinformation as well. Um, and there's unequal access to resources. And while we are trying to take care of physical health, sometimes the resources are stretched, and when the healthcare workers are stressed and exhausted, and they are absolutely at the end of their limit, and they're not able to communicate to the same extent that they were because of PPE and other things. We've seen the harm caused to patients and to healthcare workers because of stigma. We've all seen the stories of doctors and nurses who've been asked to vacate their homes by landlords, saying that we are afraid of the disease that you might carry back to us. There's been the language which is stigmatizing, which has been used. COVID patient, that is a COVID house, things like that. Um, many of us, I mean, our healthcare system was um, not robust enough to deal with a pandemic like this. We've seen robust systems in nationalized healthcare setups in many other countries crumble under the pressure. So we know that we are facing a greater challenge with a larger population and a not quite so robust healthcare system. So these are all the challenges in making ethical decisions during the pandemic right now. I'm going to introduce you to one of our patients whom we're going to be continuing to follow through this entire week. So we are going to take forward the entire discussion of all that we want to do for our patients, keeping in mind this gentleman and his family who we're going to be taking care of. So Mr. Ramesh is 75 years old. He's diabetic. He has heart disease. He is obese and he has hypertension. He's had a stroke 6 months ago. He's a former smoker and he has a dense hemiplegia as a result of his stroke 6 months ago. He's had frequent chest infections. He really doesn't walk so much. He spends most of the day lying in bed. He doesn't get out of the house. He needs help with most of his daily tasks. He can go to the bathroom and sit up and eat on his own, but he needs assistance in order to do that. He needs assistance to walk. He's cared for by his wife, and he's got two sons and daughters-in-law. One son is stays with him, and the other one is has just traveled in from abroad. So that's the situation. And now I want you to think about what you know in all your treatment of COVID so far. All of you, I know, have by now have experienced taking care of patients with COVID. This is your patient, 75 years old with multiple comorbidities, housebound, requires assistance. So, what are the issues that help you decide the way forward? What are all the factors that you are thinking of? And I want you to think beyond just the physical, but also his family situation and everything like that. And let's give it a few seconds for your responses.
Please do type your responses into the chat box and I'll take them back to Rajni.
Do we think that Ramesh might is a particularly high risk patient, or is he at moderate risk, or is he at mild risk? What do we know about age, gender, comorbidities? What are your thoughts on this gentleman?
So we're getting the answers coming in. Polypharmacy, multiple comorbidities, says Pravina. Nilya Dutt said he's high risk. Mohsin says high risk. Nilya Dutt makes a pertinent point also, high psychological risk. And yeah, so
Very important point. Yeah.
yes, very important point. And
Yeah.
it's good that that's being taken into consideration
Yeah.
as well. So yes, Yang Zom, yeah, I think the
Yeah.
consensus is high risk. Yeah.
Yeah. So we all agree that Mr. Ramesh is at high risk. And I'm really glad that the psychological the perspective was brought out, because, you know, this is the part. This is a gentleman who's had a dense hemiplegia and a stroke. He is extremely dependent on his wife and his sons and his daughters-in-law. Imagine someone like that who falls sick and now has to go to the hospital, and imagine the kind of stress and anxiety that will be caused to him and to his family members with that.
And also, Dr. Prasenjit Biswas has made a very important point that apart from clinical diagnosis, we should give emphasis in individual and contextual aspect. Yeah.
Yes, absolutely. There are many, many aspects to explore in Mr. Ramesh's care. And besides the obvious, being over 70, diabetic, male, all of those things we know, we've studied about that, but we're here to look beyond, like what are the other things that put him at greater risk? And these are all the things that we need to keep in mind. Okay, I'm just sorry, my screen seems to have frozen, so I'm just going to just hold on for 1 second and I will reload the screen.
Yeah. And also there are other points being made, I think, which are very relevant, and that's quite typical also of a holistic approach where we look at the financial status of the person in ethical
Very
decision
important
making.
point. Yeah.
Yeah, and
That is such an important point.
yeah, especially in us in our settings where the financial burden can also exponentially increase the load of suffering. Dr. Mari Joanne has said that preferences of care, what is his advanced care plan, and we need Mohsin says we need to do 3-stage assessment to this type of patient. So would you like to expand on that, Mohsin, about what are these 3 stages of assessment that you'd like to have done for Mr. Ramesh? Rajni, do you want us to share the screen from the
I think that would
side?
probably be better. I seem to have a frozen screen for some reason, so
No problem.
I think it would be helpful. Yeah.
Arun, can we please have the presentation shared from our side, please? So we were on the yeah. Oh, Rajni, your screen's back on.
Oh, okay. Yeah. So I think I'll go with Arun's screen share, then I'll stop mine. Yeah.
Okay, fine. Yeah. So yeah, so Mohsin says clinical, contextual, and individual. So do you want to just spend a couple of minutes talking about the points raised by our participants about financial, advanced care planning, clinical, contextual, individual, while the screen comes back?
So So I think it's really important to address all of these in our assessment. We know that there is the clinical part of it is we look at, uh, as we mentioned, his age, frailty. There are various measures. How clinically sick is he? Those are all things that we can look at. When it comes to the financial aspect of it, we can see that Mr. Ramesh is someone who has had frequent contact with healthcare in the last 6 months. He's had a stroke. He's had frequent chest infections. For all we know, his family is already under considerable financial strain after multiple hospitalizations or treatment issues. And this is something that will weigh heavy on their minds in case he falls sick. Um, there is the individual part of it, which is someone like him who has already been through so much will already have some degree of fear and anxiety about, I hope I don't catch this infection. If something happens to me, then what will happen to my family? How will we cope with it? These are all the things that will be going on and playing a major role in the way that Mr. Ramesh and his family respond to anything that happens to him and his health at this point. Anything that you would like to add in this, Smriti?
No, Rajni, I think you've pretty much covered it. And I think a lot of our participants who have already shared in the chat box are pretty much on the same page. And Dr. Praveena has talked about the social stigma of COVID. We will be talking about stigma in the days to come when we talk about on Friday, when we talk about managing distress, not just distress of our patients and their families, but also distress amongst healthcare workers. So I think we can have a more expanded discussion about that on that day. I'm just mindful of the time, Rajni.
Yeah, I
So
think we can move the screen along, Arun, please.
yeah,
And we'll go to the next one after this, the next screen after this. And the next slide, please. So
yeah,
so
this one.
we know that there are certain parts that we've got from studies that have been done. There's been enough in the last 10 months. We've had studies which tell us that older patients are at higher risk. We know that recovery in patients who have acute respiratory failure requiring mechanical ventilation is uh, is can be as low as 17%, and many of the patients require very prolonged ventilation and might have recurrent problems going forward. Uh, there have been certain controversial decisions made in certain countries where in the early part of the pandemic, because of the lack of resources, certain countries took decisions that people over the age of 80 would not be offered mechanical ventilation. And there was this ageism or ableism which was contested by all ethical groups. It is not considered appropriate for someone to not have access to appropriate healthcare only with age as a cutoff or disability as a cutoff. So, how do we make ethical decisions in this time? It's very important that all of us understand these frameworks. That it is about understanding the patient's medical and functional ability going forward. Most important in all of this, it would be what is the patient's wishes. We will go back to patient autonomy. Have we really had the conversation with patients so that they can make an informed decision? And that's going to be the crux of the matter going forward. Next slide, please. So we know that patients who receive mechanical ventilation, even those who were 60 plus years old, only 17% got discharged. And even at the time of these studies, many required prolonged care, whether it was continued ventilation or had prolonged hospitalizations going on for 2 3 months. We know that people develop lung fibrosis and will have the long COVID or the tail of COVID where the suffering continues much more. So this is actually going to be a part that is going to be with us for a while. Even in the palliative care community, we're going to have to address the fact that COVID is a disease we're only starting to understand, which has sequelae, which affect the lungs, which affect the heart, which affect mood, which affect neurological, neuropathies and things like that, that we're discovering now as the long effect of COVID. All of these patients will require continued support. And these are things that should help us to make a decision, even in helping the family with framing goals of care. Next slide, please. Now, the key ethical principles, as I mentioned earlier, are going to be with the examples of countries which chose age and ability as a filter for access to intensive care. Is the principle of non-abandonment. At no point should any patient feel that they are being abandoned by the healthcare system. No person in need of medical care should ever be neglected or abandoned. And even if they are not going to be benefiting from intensive care, everyone should have access to palliative care. And that is the goal of these multiple collectives across the world that they've put together as a common principle for providing optimal care during the COVID-19 pandemic, which is non abandonment, respecting people and autonomy, that reciprocity. This is something about protection of the public and provider. This is the fact that healthcare workers need protection. It cannot be that healthcare workers who are putting their own health at risk and their families at risk are not provided adequate healthcare when they themselves fall sick. We've heard of postgraduate students being penalized if they contract COVID virus, as in, oh, it must have been some mistake on your part, therefore you have got it. Or they've been told that if you've taken days off for being sick, then you need to serve extra in order to get your postgraduate degrees. So this kind of punitive response to what is actually suffering of even the healthcare worker is not to be is to be absolutely condemned, and we need to make sure that we support patients as well as healthcare workers. Confidentiality is of absolute essence, and we look at holistic care, the whole person care, looking at spiritual support, bereavement as well. And in all of this, we try and maintain justice and fairness. These questions are going to come up again when the vaccine does become available. We will come across these questions of ethics, of justice and fairness. Who should have access to the first doses of the vaccine? The most vulnerable. Who are the people should have access to it? Because we know that already there's a lot of lobbying going on with richer nations, and LMICs will be at a disadvantage in obtaining enough amounts of vaccine. Next slide, please. So, when we're looking at triage and goals of care, it's important to have a plan and strategy in place. And the fact that we communicate all these appropriately to everyone. So, within each city, district, town, the healthcare system's communications of what is to be done when someone is tested positive, how do we trace it? If we have a plan and strategy in place and the information is given to communities, then that helps a lot in being able to coordinate the care and make sure that the appropriate level of care is given for mild, moderate, and severe disease, and providing appropriate care. You might have seen videos of COVID care centers, which are purely isolation centers, where patients are listening to music or doing activities together. And that's the kind of thing we're looking for. You're looking for the psychological support to someone who's separated from their family and going through the anxiety of having a disease and wondering, am I going to get worse? Am I going to get shifted to a hospital? But if if the director of a COVID care center says, I am going to address not just the physical but also the psychological and spiritual needs of everyone there, along with the staff, it's going to boost the morale of the patients as well as the staff. So this is the kind of thing we're looking for, that you have good communication and systems in place to provide holistic care for the patients at all settings, whether it's mild, moderate, or severe. The next slide, please. Now, when we look at the goals of care discussion, this algorithm is there in your ebooks, and I would urge you to have a look at it for confirmed or suspected COVID cases according to their age, according to their comorbidities. How does one prepare for the eventuality in case they test positive? So before they have, I mean, just to be prepared as to what are the things I need to discuss with someone in this age group or in that age group, understanding the kind of decisions that will come up, and understand that it's important to have these conversations early. If you go back to the example I shared about my friend, it was important for the doctor to speak with the family early on, so that even though it was terrifying for them, they were able to make the arrangements early on. We realize that we have limited time, so our skills are going to be tested. Our communication skills need to be top notch in order to be able to provide the right support and guide families in their decisions right now. Next slide, please. It's important that we document these communications as well, especially when it comes to decisions where it is about certain ethical decisions about non-beneficial treatment, to understand which patient may not benefit from intensive care, and or if a patient has expressly wished that they would not want a certain kind of treatment, that we manage them according to that. It's also important that no matter where the patient is triaged to, whether they are in the ICU or in the ward, we address all their suffering. If they have any symptoms which are progressive, which are refractory, whether a patient is in an ICU or in a ward, through the next 4 days, next 5 days, we will understand that we have the means to provide relief of suffering for all these patients in every setting. And the fact that end of life care is very important, and to provide bereavement support to families. One of the things that has distressed families the most is the limited communication. So we will also have a special session on communication to make our communication more effective in this setting of COVID-19. Next slide, please. Now, this algorithm is for patients with COVID to help us understand where we might have, where the pathway for Mr. Ramesh might lead us. Um, on the screen, it might appear small to you. It is in your ebook, but it's actually a very simple to follow process if you just think of it as green, yellow, and red. When we look at patients with COVID, if they have no comorbidities and no other premorbid conditions, we can treat them for COVID-19 with whatever is the measure required for the severity of their disease, keeping in mind that these patients, majority of the patients with COVID, 85 to 90% will do well. For patients with COVID who have comorbidities and have a poor pre-COVID performance status, their functional status is low. These are patients who may or may not do well. So we give a trial of non-invasive ventilatory support if they are starting to develop signs of respiratory failure. And we start the communication with the family early on to find out what are their wishes. Does the patient have any previously expressed um, preferences about their care, about advanced care planning, things like that, and whether they're likely to benefit or unlikely to benefit. If it is evident that the patient is unlikely to benefit from escalation of care, then we go on to the pathway which is outlined in red, where we know that even if this patient is going to deteriorate, we are going to maintain that this patient gets the appropriate relief of suffering at all times. In case the patient is likely to benefit from escalation of care, we move on to the ICU for critical care arrangements, and hopefully the patient improves and gets out of the ICU. Or the other pathway might be that despite the best efforts in the ICU, the patient may deteriorate. And if that happens, again, we make sure that the patient has the right palliative care support for relief of symptoms, and communications with the family are ongoing to provide support to the family in their time of grief and bereavement as well. Next slide, please. So these are the things that will help us to decide for Mr. Ramesh. When we look at the performance scale for Mr. Ramesh, we can see that Mr. Ramesh is someone who is um, housebound for more than 50% of the day. He's reasonably symptomatic. He needs assistance to walk to the bathroom, and therefore he's at a higher risk. Next slide, please. If we look at other kind of scores that we can use, which is the organ failure score, we can see again that he has a significant amount of, he's got multiple comorbidities. In terms of clinical frailty, he is also moderately frail. So these again put him at a higher risk. So the best situation that we're looking at is Mr. Ramesh is going to follow a yellow to red pathway. And as soon as we look at these pieces of information, we are then aware of what should be the level of advanced thinking and advanced triage we start planning in our mind and communicating to the family from an early stage in an appropriate and compassionate manner. Next slide, please. So, Mr. Ramesh, if you can advance the slide, Arun. So we come back to Mr. Ramesh. As we mentioned, he's housebound, needs help. What do we think now? The next question, if we can look at, if you can advance it, Arun. So we looked at what are these issues. Many of you brought these up, that these were going to be the issues. And we looked at the clinical part of it, which was the comorbidities, the WHO score, the frailty, uh, and and some of you brought out the psychological aspects, the things that will stress him about finances, and someone mentioned stigma as well. And all of these things will play a role in the kind of support we have to provide to the family going forward for Mr. Ramesh in case he should fall sick. Next slide, please. So he's at high risk of a very poor response if severe respiratory complications occur in COVID-19. These are the kind of patients that all the governments have said that, you know, you try and restrict their interaction. You kind of have one assigned caregiver in the family, so you minimize their interactions with too many people who are traveling or going in and out of the house. But despite that, we know we have seen patients who have not stepped out of their house in 6 months who have also been positive, because it's extremely hard. And I think we've seen that happen, that I think all of you are aware of the news over the weekend that somebody like a leader of a nation where everyone is tested pretty much multiple times in a day with a lot of protection is also susceptible to infection. So we know that with the best of care, there is a likelihood of being exposed to the virus as well. So being prepared for the eventuality is what helps us most, and having those decisions kept in mind. Next slide, please.
Rajni, there are a few interesting points that have been raised
Yes,
in the chat box that
absolutely.
we will come back to after we finish the presentation, so that
Sure,
we can just
sure,
focus on that discussion. Yeah.
sure. So yes, next slide, please. So a little more background information. We were looking at the psychological and financial aspect. Mr. Ramesh is 75 years old. He's a retired mechanic. He lives with his wife, Radha. Suresh, his son, runs a provision store locally. So, they've been financially challenged because he's not working anymore. Son runs a provision store. We all know that stores have, small storekeepers have suffered a lot in the lockdown. His other son, Manish, has returned with his wife and son 5 days ago from his job in the hotel industry in UAE, which has also taken a hit, and they are currently on home quarantine. They live in two small rooms in a semi urban area. Ramesh used to be active, but now he's been housebound. The neighbors keep calling them that he is at risk, you should be careful. He reads that elderly are not going to be treated and asks his family doctor what will happen to him. So, all those issues that all of you had raised, these are the real issues that Ramesh is going through. Next slide, please. Um, yeah, so how are we going to respond to these concerns? This is something for us to think about. And I think all of you've already brought up all these points, so I know that you've seen it in your practice, that these are things that we need to address. Next slide, please. So when we are looking at this in terms of triage and goals of care, we're going to be looking specifically on one entire day on communication skills. And if we are that family doctor for Ramesh, how will we address his concerns will be by telling him all the ways in which he can be safe, and making sure that we provide that assurance. We've seen a rise in telemedicine across the world, and we found new ways of using technology to provide what we are unable to with the human contact. So the fact that we can be present with the patient, whether it's over the phone, whether it's over a video call, whether it's a telemedicine consult, in our busy lives, even if we can focus for a little while and understand what is going to happen to me, what will happen to me now, those kinds of questions, understand where the fear and anxiety is coming from. We emphasize on the verbal and non-verbal. We make sure that we preserve dignity, maintain patient autonomy, and we work as a team, so that this is the greatest fear for most people, that they don't want to be alone. And if we can assure them that that non-abandonment principle that we were talking about as one of the key principles in this, then that would be one of the main ways in making sure that we're able to provide some support for our patients. Next slide, please. So our aim, to sum up, is to preserve the continuum of care and to make sure that all our triage and decision making of goals of care, shaping goals of care, is in line with the ethical frameworks, that our communication is absolutely effective, and as effective as possible, using all the means that we have, with the barriers of PPE, with the barriers of physical separation, that we guide the families in shared and supported decision making regarding escalation or de-escalation of treatment, and that we provide holistic support, and make sure that we address according to the person's values, that the care given to patients should be in line with their values and ethical principles as well. The next slide, please. In all of this, there have been times that we will get frustrated. There will be times when we snap in anger with what is happening, when we feel that we are ineffective, that we are useless. And nurses from across the world have spoken about the strategies they use to keep their motivation for going into work. they are witnessing suffering at levels that they have never seen before. But very often, they are looking for ways to fill in that. um fill in their hearts with the amount of care necessary in order to provide it to their patients, because when there are times, one of the nurses whose accounts I had read, he was an ICU nurse, and he said that, all I do every day when I go home is try and fill myself up with as much goodness as I can, because I know that I'm losing more patients than I ever did in my life in 1 week. And if all I can do is be there with them, holding their hands, that is the maximum that I feel I am able to do. It's very hard to stay human in all of this. It's very hard to nurture your soul while you are going through distress in one of your most difficult times as a healthcare worker. It is painful, but it is what is needed to be done to keep going right now. Next slide, please. Um, we talked about people who've been in humanitarian crisis, and a student from Gaza mentioned this idea of humanity until infinity. The word social distancing was used in the early days of the pandemic, and we've all decided that that was an inaccurate description of what needed to be done. What was needed and what we are practicing is physical distancing, but including through measures like this program, we are practicing social togetherness and global solidarity with the knowledge sharing that we are all engaging in trying to provide the best care for our patients. It is very painful, the process that we are going through, that understanding and knowing that there are some patients that we are unable to um, help in terms of recovering from the disease. One of the biggest problems in healthcare has been that for a long time, medicine has been taught in a way that we look at death as our personal failure. I think it's important for all doctors and nurses and therapists and social workers and counselors and everyone who is involved in this to understand that this is a disease like we've never seen before. There is no personal failure when it comes to COVID-19. We are all doing the best that we can, and we hope that in the next few days that we are able to share with you some of the ways which have helped many of us, and we also learn from you. Next slide. There are plenty of resources that will be available on these that you have, especially with the ebook and multiple other organizations' websites that I would encourage you to reach to look into. And the next slide, please. So more such resources. And with that, we come to the end. Thank you. The next slide. And I'd like to thank the entire core team of Pallium India and PalliCovid Kerala who put together this program for all of us that we've benefited from, and hope to see all of you again in the next few sessions. We have, I think, hope we have a few minutes for discussion. I know across the time maybe Smriti, but you mentioned that there were some interesting points that we could discuss, and if we can have Sister Stella weigh in as well. And I don't know if Dr. Raji, who's the mentor for the week, is there as well.
Yeah, Dr. Raji is the mentor for the following week. Arun, if you could stop sharing screen, please. Thank you so much, Rajni, and thank you all for your inputs. Rajni, I think you have access to the screen now. I'll draw your attention to a couple of points made towards the end by Dr. Owais, who talked about residual generalized weakness remaining for a long time, and counseling of patients is required for the same, or recovered patients get undue stress. And they've also shared that another important point in COVID-19 is deceptive hypoxia, which doesn't
Happy
lead to
hypoxics that we
breathlessness.
spoke
Yeah,
about. Yes.
happy
Yes.
hypoxics. Yeah, and he's raised several points there, which I think you can have a look at towards the end. I was very, very glad to see someone mention dignity therapy. That's not something that is very widely known, but I think it's gaining traction. So that was something that, because personally, I've been a great proponent of dignity therapy in our practice, and it goes extremely well with what we try to achieve. If you can just look at Dr. Owais's comments down the bottom. In fact, Dr. Owais, would you like to unmute yourself and just let's make this a discussion rather than me reading out your words? And if everybody's okay to hang out for another 5-10 minutes, because this is such an enriching discussion, please do stay on. I know we're past the time of closing, but I'm sure we'll close up in another 5 to 10 minutes. Dr. Owais, please go ahead and share with us your experience. I think one moment, we're just giving you the unmuting option. For those of you who are leaving and dropping out of the call, please do remember I mean, the poll will only be up later, but do fill in the pre-evaluation. Okay.
While we're waiting for Dr. Oves, I mean, I'll just quickly address those points that he brought up. One is the hypoxia, and yes, that is something that is extremely important. So this is something that comes up, especially in the home treatment of patients with milder disease, that we advise them of the importance of monitoring their saturation. And even when they're at home, we advise them to monitor their saturation 3 to 4 times a day. If they have access to a pulse oximeter, there have been certain governments which have provided pulse oximeters to patients who are on home treatment. And if there has not been the ability to do that, then I know that certain cities in Maharashtra, for example, have said that since we are not able to provide enough pulse oximeters for home monitoring, it is mandatory that even if if you're asymptomatic or mildly affected, you must be in a government sanctioned COVID care center so that you can be monitored for this. Because we know that there are patients who might not feel that they are breathless, but they are hypoxic. And these are the patients that we watch out for, the ones who could become mild to moderate and then to severe rapidly. That is something to be aware of and to counsel patients about. Regarding the point about cost of remdesivir that Dr. Oves brought up, yes, the cost of treatment is pretty high. And that again is one of those things which is stretching our resources in the government. And we know that in the private setup, exorbitant prices are being charged. There was a point when multiple other drugs were in use, and again, those were very expensive. Tocilizumab was in favor at one point, but that's gone down now. So these are things that will keep evolving over time. What we are trying to stress on in these sessions is that the basics of nursing care, the basics of intensive care remain the same. And we will see that tomorrow in the symptom management session as well. Things like proning, it's awake proning is something which has taken which we were propagating early right from February onwards, and we found it to be very effective. If we advise patients to do awake proning even at home with mild hypoxia, they are doing much better. So there are ways of trying to work around the fact that so if we keep in mind that good nursing, good clinical bedside care is still the best thing for a viral illness, and it's only a small percentage of moderately severe patients who require the higher end and expensive treatments.
Yeah. So apart from that, I think also people have pointed out other psychosocial issues that people face at a time like this, counseling in the long term post recovery. We've also, there are people who've talked about, you know, one second. About a holistic approach, and because the psychological impact, the psychosocial impact is long term. So even once the person recovers and is COVID negative, the psychosocial impact on the family as a whole is quite long lasting. So we will be covering some of those aspects in our managing distress session, like I said, on Friday. Yeah, so Jacinth has talked about how can palliative care for COVID-19 be managed for elderly patients suffering from neurological diseases like Parkinson's, who suffer from severe mobility issues. I don't think that's in the ambit of these 5 days that we do, Rajni, but certainly there are other courses. But if you want to add to that, then.
No, I think so. Palliative care for COVID in elderly patients with neurological diseases, there is, when we look at palliative care, neuropalliative care in itself for patients with Parkinson's or motor neuron disease and everything else is a separate specific topic in itself. So those principles will apply here. For patients who have mobility issues, we need to make sure that the nursing staff is sensitized. So there are ways in which we as healthcare workers can respond to the anxieties and concerns of the family members if such a patient is hospitalized with us. Any patient with, even Mr. Ramesh, for example, he has dense hemiplegia. He might have difficulty communicating with the nursing staff in case he falls sick enough and needs to be hospitalized. So these are all going to be the things that we need to take special care of. Patients who have, for example, patients who have a hearing disability, patients who have a visual impairment, when these patients who might have a mental disability, if these patients are contract COVID and they're infected with COVID and have moderate to severe COVID requiring hospitalizations, they will require special considerations for their situation, and their families will also require that extra bit of support. I think Dr. Praveena brought up an important issue of cremation issues within religion, and we will be taking that up in the end of life care segment later this week, Dr. Praveena. Yes, there are issues regarding the last rites for patients and the sensitivities around that in the context of the pandemic as well.
I'd just like to invite Sister Stella to come in with a few comments from her perspective. Sister Stella is one of our faculty. She has worked as a nurse. She's been with the Army for many years, and she's one of our senior most palliative care nursing experts in our palliative care community. Sister Stella, may I ask you to please share with us some of your thoughts before we bring today's session to a close? Is Arun, is Sister Stella here?
Ma'am, I think it's not there. No.
All right, fine. Okay, she's
Okay,
probably
fine.
dropped out. No problem. So we're at the end of our first session, and I'm so pleased to see that it's already a very enriching and interactive discussion. I'm sure all our participants have a lot to share with us as we go along. I'm going to request that before you leave, there's a poll that's going to be shared. Please do fill that in. And tomorrow's session is on symptom control. It is led by Dr. Rajam Iyer, who is a pulmonologist and a palliative care specialist, and Dr. Sunita Daniel, who's a palliative care specialist, and who's one of the key people behind the ebook and the resource toolkit. So tomorrow also we have wonderful people leading the session. Please go through the resource toolkit and come prepared with any sort of discussions that you'd like to have with the experts. And yes, Rajni.
Thank you so much, Smriti. And I want to thank all the participants. I'm looking at the names and places that all of you are from, and it is so heartening to know. Again, as I mentioned, this has been the most heartening response across the world in the pandemic, which is the healthcare community coming together to support each other in being stronger to be able to provide the right care to our patients. And I wish all the very best to all of you. Take care and stay safe, all of you. Look forward to seeing you again on the upcoming sessions through this week. Thank you so much.
Thank you.